Hello, class. I'm going to record this review lecture. Someone said the last one was useful. And so again, there's going to be no new information here, and I'm not going to go over everything that's going to be on the test or that I went over the last few weeks, but I just went through the lectures and just picked out some major points so that I can, this is helpful to one of you, to do better on the exam, then it's worth it. So I'm just going to talk about, go over everything and yeah, and we'll just see how it goes, and hopefully these things will help you stick. And by now, by me lecturing this time, you should know, the stuff that I'm talking about. It should be a review, and if you notice something that you didn't know anything about, then that's going to tell you should study that. All right, so we'll go through it all. So cardiovascular system. So I'll do this, and then I'll do an immune system one. Yes, here we go. Let's see. So big chapter, important one. Again, it's just stepping back. I mean, the function of the cardiovascular system, what is it? It's going to be the pumping heart, which is going to provide the pressure difference. When you have a pressure difference, you're going to have flow. That's going to cause the blood to course all about your body. And of course, it starts beating before you were born and until death. It's often a signature of death when it stops beating, of course. And functions the cardiovascular system, I mean, the blood, besides carrying oxygen and glucose to your tissues, it's going to carry away carbon dioxide and waste products. It's going to carry your hormones. It's important in your temperature regulation. So that blood, it takes all your nutrients from your digestive system and delivers them, etc. So lots of important functions. The hearts, again, you guys need to know, there's going to be questions on the anatomy and then the physiology, the electrical and the plumbing. And vessels is just a general term for arteries and veins and capillaries. All the vessels are all the tubes in this closed system of the heart. And again, big picture, you have two circuits. You have a pulmonary circuit where the right side is going to pump blood to the lungs. And the lungs is going to pick up oxygen, get rid of carbon dioxide, and it comes back to the left side to the systemic circuit, which is going to leave out the aorta, which goes to the system, which is all of your body. And then once that blood has been used up, it comes back to the right side to begin again in the pulmonary circuit. So with each beat of the heart, you have atria, contract, and ventricles. This dual system is going on. The ventricles pump it out to the aorta and pulmonary trunk, and the two atria receive it from the body, used up from the body, and from the lungs, ready to go. Anyway, just make sure you know path of the blood that's going on, and of course these two systems are very important to know. And again, the heart, where it sits, right on your diaphragm and the chest. The mediastinum is the area between the two lungs. That we'll get to later. I'll throw more terms at you, but there it sits. Pericardial sac, probably a question about that. You didn't see it in the models in lab, but it's important here to know that your heart sits in this really tough fibrous sac, and it has 3 layers to it. Let's take a look here. Yeah, so the sac itself, which was removed from the sheep heart and stuff, is going to have a really tough fibrous layer out there, super tough. I mean, it doesn't give it all. And then there's a double layered sac here. There's a layer on the heart, and then on the inside of that fibrous layer, called the visceral and parietal pericardium. All right. And then the pericardial cavity is a small space in between it with lubricating fluid. So you got a visceral layer, also known as epicardium. And then you have a space with a little bit of fluid. Then you have the parietal, and then the fibrous layer. And that's that pericardial sac. And if you look at the heart itself, the layers of it, the inside is the endocardium, nice and shiny in the inside. The myocardium is made up of the muscle. And then the epicardium, also known as the visceral pericardium, is the outer layer on the heart muscle. Beautiful. There you go. So in life, that heart is stuck in the sac. And I hope you all understood, when you look at that visceral and parietal layer, they're actually continuous. It developed as the heart pushed into this membrane. And so you end up with this layer on the heart and then the layer on the outside like that. Yes. And then through, and don't forget, there'll be questions about myocardial infarction and in this case, pericarditis and endocarditis are infections on the pericardium and the endocardium. So an infection on the membranes on the outside of the heart, or on the membranes, which also go over the valves, which is usually the issue. We have bacteria growing on the inside of your heart and on your valves. Indeed, this is something, this and the arteries and veins of the body is just something to memorize. I mean, there's no something like complicated conceptual issues here. It's like learning a map. You just need to put the time in. You need to write it down so that you can quickly draw out the heart and know exactly where the blood as it flows through the heart, just like that, and where the valves are. Yeah. And so I don't think I need to go through this. Just real quickly, I mean, the blood comes into the right atrium through the vena cava and the coronary sinus that drains the heart itself, through the tricuspid valve to the right ventricle, the smaller of the two. I guess I'm popular. And then it's going to shoot out of the right ventricle at the pulmonary trunk to the pulmonary arteries that go to the lungs. And again, arteries go away from the heart, veins towards the heart. And then back from the lungs through the pulmonary veins to this left atrium. And then the left atrium down past the bicuspid or mitral valve to the biggest chamber, the strongest chamber, your left ventricle. And that's providing the power to shoot it out past the aortic valve, out the aorta, into the body. All right, basic anatomy. You know, all those vessels coming out. I will talk about these a little bit later, but the rest of the vessels, the valves, right? The valves are going to be on the right side, it's going to be tricuspid. The left, you need to know it's called bicuspid or mitral. And then aortic and pulmonary valves, technically aortic or pulmonary semilunar valves, because they're made up of 3 half moons like that. Okay. And then auricles are these little extensions of the atria that come around like that, right? Looking at this, I can see this is going to be the anterior interventricular sulcus. There's going to be a sulcus up here, goes all the way around the coronary sulcus, filled with fat and vessels. If I could, this was a real heart, I could pull off the saran wrap, it'd be the epicardium or visceral pericardium. And then really fascinating how you have in your heart, yes, you're going to have a 2 remnants of fetal circulation. And as a fetus, your lungs are filled with fluid. You're not getting oxygen there. You're getting oxygen from mom's umbilical cord. And so you have 2 things in the adults. You're going to have this oval depression, fossa ovalis, and this arterial ligament. And these used to be openings in the fetus, but now they're closed off as an adult. So in the interatrial septum, there used to be a hole, and there used to be a little duct between the pulmonary and the aorta right here. And both of these were shortcuts away from the lungs. Here's the sulci again. It's something people maybe neglect sometimes, but this is the coronary sulcus right on here, posterior, and there's going to be anterior interventricular sulcus. And the walls between the atrium ventricle are the septum. So interatrial septum, interventricular septum. And people have septal defects in their heart, where there's often a hole in the heart wall. And the valves, again, I think we've gone over this so many times in lab and lecture. I feel like you guys should know this, right? Here's your tricuspid on the right, bicuspid on the left, aortic and pulmonary. And then to put together the heart sounds, you should know that the first sound are these big ones, the lub, and the second heart sound are these smaller ones closing. So lub dub, lub dub. A mitre is like the hat on a pope. All right, what do you guys think? And then if I ask you, do these chordae tendineae and papillary muscles, do they close the valves? No, they do not. They close just because of the pressure in the ventricles. They're closed, and then these things keep them from flipping up, from pushing up into the atria. So they keep blood from leaking back into the atria once it's in the ventricle. Once they close. So papillary muscles, chordae tendineae, are attached to the atrioventricular valves. And then heart disease stenosis is going to be a narrowing. And then this is just, look at these ugly valves. Just realize a lot of valve issues, especially in the aortic and mitral valves. They harden and they become inflexible and narrow. And then your heart works harder to push it past that, and you get high blood pressure, et cetera. Skeleton of the heart, there's no bone in a human heart, but it's going to be connective tissue right here. That's gives strength to the valves, one, and two, it's an insulation from electricity between the atria and ventricles, so that the atria contract, then there can be a delay, then the ventricles contract. That skeleton keeps it from just going from the atria to the ventricles. Yeah. This is just another view. So hopefully you guys understand your circulatory system and how the heart pumps the blood. The circulation of the heart itself, just real quick, you have two coronary arteries. This is the first branch of the aorta, will be the coronary artery. So the heart gets it first, gets its blood first. And you can have a right and a left coronary artery. And then the right comes around, makes a marginal along the edge, and it goes to the back to make a posterior interventricular. The left comes off the left, and it's going to make the anterior interventricular, and a circumflex, which is going to circumflex around to the back. And the veins of the heart are called cardiac veins. There was coronary arteries, but it's cardiac veins. And the only one I want you to know is the big one in the back is the coronary sinus. That's going to drain into the right atrium. It drains the entire heart muscle. And an angiogram is when you get a picture made of this. Very, very common because of people have angina or heart attack. They want to see, usually it's because these vessels are occluded or narrowed, and they can look at that with an angiogram. And you should know kind of a pre-heart attack is angina. Angina is this pain, you feel like you're having a heart attack, but with rest, you feel better. But get to the hospital because they need to do an angiogram and like, oh, okay, you have a narrowing of an artery because you exercised and you pushed it. But a real MI, myocardial infarction, is when part of the heart muscle dies because of ischemia, because it has lack of blood flow, it has lack of oxygen. And as I mentioned, heart muscle doesn't regrow, and so you end up with this scar on your heart. So a person that survives heart attacks, the heart becomes less and less effective because cardiac muscle doesn't, repair itself. It just turns into this scar, so it's not helping contract. Yeah. And of course, things you can do against it would be a coronary bypass, or you can put a angioplasty where they put a balloon in there, or a stent that's is in there that keeps it open. All right, this is review, so I'm going fast. Hopefully you guys are like, yeah, bypass, I know what a stent is. Okay, yeah. If not, you're like, well, then pause it and make sure you know, or go back. And then when you hear of hypertrophy, ventricular hypertrophy, it's when it's just like your muscle's grown too big. And remember, two causes: either it's good, you're in shape, or your heart's working too hard. If you have hypertension, your heart just keeps getting bigger because it has to push against that pressure kind of thing. So, all right. And of course, systole is contraction and diastole is relaxation or dilated. It's going to open up. And so when we talk about the heart as a whole, we talk about systolic over diastolic pressure, 120 over 80, something like that. Well, systolic pressure is when the ventricles are contracting, the maximum pressure. And the diastolic pressure is when the ventricles are relaxing and your blood pressure is at its lowest. And indeed, what happens is that these atria fill. They're actually relaxing while the ventricles are contracting, so they fill up with blood from the body and the lungs. And then what happens is that as these ventricles relax, they make a suction, and actually about 70% of the blood just gets sucked down there, just sucked down there. And then when the ventricles are expanding, then the atria will contract, and they'll push that remaining 30% of the blood so that the ventricles are completely dilated. That'll be your preload. That'll be the end diastolic volume. That's at the end of the ventricles relaxing, they have the maximum blood in them. All right. Then those ventricles will contract. And so that pressure will cause the blood to want to go back up to the atria. But the mitral and tricuspid valves will snap shut, and the blood can't go that way. So it has to go out the aorta and pulmonary trunk. So as the pressure increases, eventually it's going to be expelled from the heart. And then the ventricles will contract to get rid of the blood, but not all the blood. Remember, there's always like 50 mils left in there, and then it will, the ventricle will start relaxing again, and that will tend to suck the blood back in from the arteries it just left at. And those semilunar valves will shut. And then the atrioventricular valves will open and blood will come down from the atria again to fill up again. So that was the cardiac cycle, me kind of miming it for you here. But hopefully you saw what happens and what valves close when. Yeah, if not, just work on it. And you can look up YouTube videos. There's all kinds of things out there just so you understand what happens in the cardiac cycle. And once you learn, I've done it a million times, you know, you can go through the whole thing without any issues, and you'll be able to answer multiple choice questions easily. Yeah, I think I explained it. And then you know what causes the heart sounds. The big tricuspid and bicuspid valves, when they close at the end, when the ventricles are contracting, the first sound. And remember, lab, the first sound will be here, lub, and then dub. So when the ventricles close, when the ventricles relax, will be the sounds of the AV valves and the semilunar valves closing. Lub dub, lub dub. And a murmur is going to be an unusual heart sound, and it's usually a valve issue. And then remember, with valve replacements, you can get either artificial or pig valve. And then the deal is with artificial valves, you need blood thinners forever, but they last longer, but they click. All right. All right. And cardiac muscle, remember, it has its own rhythm. It goes on its own, kind of too slow, but it goes on its own, it contracts, right? And all the atria and all the ventricular, we're talking about being syncytiums, atriosyncytium, ventricosyncytium, because they contract as one, even though they're made of millions of individual cells, right? So the signal goes really quickly between cardiac muscle cells. These intercalated discs are the connections between two cardiac muscle cells, and they have gap junctions. They have big holes in them. So when this contracts, the next one contracts. Just the signal goes really quickly. But the pace, if you let the heart go on its own pace, it would be like too slow. So we have an SA node in charge. It just happens to be the fastest node, so it's going to be calling the shots. It's going to be calling the pace. And do realize it wants to go at 100 beats a minute. Crazy fast. Well, unless you're working out, but like resting crazy fast, right? So you always have the vagus nerve, that sympathetic nerve, slowing it down to your normal 60, 70 beats a minute. Cool. So the SA node continues to fire, right? 60 times a minute, something like that. And the signal goes all over the atria. And it can't go to the ventricles because you have that skeleton of the heart that insulates it. But all the atria is going to go. And then here's going to be little junctional fibers, which are really small nerves. And the junctional fibers, because they're so small, the signal goes really slowly. So it goes really slowly. And this AV node, the signal goes very slowly through it. So that's that delay between the atria and ventricles. You have to have that delay. You can't have the atria and ventricles going together because nothing would happen. You need atria, delay, ventricles, delay, atria, delay, ventricles. So that the junctional fibers and the AV node are what slows it down. And then when it fires, it's going to go down this bundle branches, the right and left bundle branches, and eventually Purkinje fibers that just really rapidly carry that signal from the apex of the heart up. So that when the ventricles contract, they go from the base upward, and they actually squeeze it, wring it out. They have kind of the fiber direction is like spiral. So it wrings out the blood, it shoots it out the aorta and pulmonary trunk. And doesn't empty them. Remember, your end systolic volume, there's always some blood left in there. But the stronger your heart, the more it can pump out, just to throw that at you. Cool. And just from this, just know that, if your SA node is not working, the AV node can take over, though it's slower. If that, even the Purkinje fibers can fire. But see, they're firing really slowly. So yeah, so the SA node normally is the fastest and it's in charge. You get what's called a sinus rhythm, which is the correct rhythm. But if something's wrong with it, other things can take over. But it's not as good. Yeah, so there you go. Just how the electrical works. Make sure you know that. ECG, I think I teach, wait a minute, 6 labs of this, right? Is that all? 6? Yeah, like 6 labs. So I teach this a lot, right? And then 2 lectures at least. So talk about ECG. So hopefully you guys, you've had it a couple times, you know what to be able to read an ECG. And you put electrodes on the skin and it measures the heart electrical activity. Pretty awesome. So, P, Q, R, S, T, P, Q, R, S, T. Yeah, continues, yeah. Know the parts of it, know what's going on. Know this is gonna be the atria depolarizing or contracting. This big thing here is huge because it's the ventricles. Big muscle is gonna be the ventricles depolarizing and the atria repolarizing. And then the T wave is gonna be the ventricles repolarizing. Yeah. And then this T to P interval here is between the heartbeats. Could ask you a couple of arrhythmias. If your heart's going too fast, you have tachycardia, too slow, bradycardia. And I also mentioned a block. If you have a block, it's keeping the signal from going. And you may you get a longer delay between the P and QRS, and you actually miss one because it's being blocked. And then you need to know AFib and VFib. So look at those. Yeah, so all together, and again, in lab, that's why we do this. We know when the heart sounds, phonocardiogram. This is an electrocardiogram. Electricity, the sound in the heart. And then you can look what's going on, the pressures and the volume of the chambers. Yeah, very cool. All right, and what controls your heart rates? Clearly, the SA node can be talked to by the parasympathetic system, your vagus nerve, and also has sympathetic nerves, or just straight up adrenaline, epi, can make it go faster. So this is going to speed up, slow it down, brakes and gas pedal. But also the warmer you are, the faster your heart rate. Obviously exercise, it will double your heart rate really, really quickly when you're on the treadmill, right? Your ions, calcium, potassium especially, can speed up or slow down the heart, definitely. And who's in charge? It's going to be up in your medulla, your cardiac center and your medulla oblongata. There'll be an accelerator and an inhibitor, like brakes and gas pedal. And it's all going to depend on your body's needs. Pacemaker, artificial pacemaker, just realize it has wires that go right into the heart, and it can regulate the pace. It can defibrillate if it has to. It can record your entire heart activity for days and months. So cool stuff. All right. All right, good. We'll get to blood pressure, cardiac output in a minute. Obviously, blood vessels, you need to know about them, their anatomy and what they do. So, I mean, the big thing is arteries leave the heart, your big aorta, carotid arteries, your radial artery. The arteries are the big ones, muscular, powerful, high blood pressure. Arterials, when they get really small and they start having little sphincters, so you can shut off capillary beds after them. And then the action takes place in the capillaries. That's where exchange takes place. And they're just the width of a single blood cell, a little bit bigger, and no muscle on them, just a naked epithelial cells. And then venules will collect from the capillaries, and then your veins are big but thin-walled, low pressure. They have valves in them. We'll bring the blood back. Yeah, and looking at the anatomy differences, arteries, thick-walled, lots of muscle. Veins, thin-walled. I got some valves in them, though. And could talk about the anatomy of the vein. You've got a tunica. Tunica is a coat. The intima, the inside. The media has the muscle. And then externa, or sometimes adventitia, is the outer connective tissue. The term angiogenesis means blood vessel birth or creation of blood vessels. Yeah, there we go, like in Genesis in the Bible, right? So realize with angiogenesis that it's bad in cancer because the tumors will send out these factors that make blood vessels grow, so the tumor will grow faster, right? But we do want this vascular endothelial growth factor, this angiogenesis chemical, like in areas where we want to regrow or heal, because it's going to, more blood vessels brings more nutrients and allows something to grow, like in a heart attack. Yep. So capillary beds are where the business is, and you can open and close different capillary beds. If you eat a big meal, open the capillary beds in your gut. Exercising, close those down, open the ones in your muscles. And the physiology, this is very, very important here. When you look at how capillaries work, is that in the arterial end, which would be the beginning, you're going to have a higher blood pressure, and it's going to force out a lot of fluid. And you always have osmosis sucking it back in. And on the venual end, the venous end, when it's almost to the end, you've lost that blood pressure. As it goes through, it's going to lose that blood pressure. So, damn, not as much as going out, but osmosis is more of a factor here. Because you've lost the water, so the blood itself has all the albumins and all the salts, everything in it, right? And so water is going to be sucked back into the blood, but not all of it, right? So more leaves that get sucked back in. There's always a little extra, and that gets carried away in your lymphatic system. It carries the extra fluid around your cells and brings it back to the blood. Next lecture, right? I hope you guys got this. This is what happens. Capillary beds, water leaves because of your hydrostatic pressure is greater than osmosis. It's going to wash over your cells. At the other end, that water is going to be sucked back into the blood, most of it. Veins have valves, helps it get back. And then if I ask you, where's the most blood kept in your body? It's not equal arteries and veins. Veins. Your veins are a reservoir for blood. And if needed, those veins can contract. Like if you bleed a lot, you'll lose a lot of blood. Those veins will contract and like return that blood to the system to help keep your blood pressure up. But in normal everyday people, the veins are just, they're bigger and the blood has less pressure, so it kind of backs up in the veins. All right, this term, cardiac output, is how much blood leaves your heart every minute. Simple formula. Going to be your heart rate times your stroke volume. It's how much blood is pushed out with each beat. So on average, you need to know it's about 70 mils is the stroke volume. And if we just average, say, 70 beats per minute, it's damn close to 5 liters every minute. So your total blood goes through your heart every minute. All right, so that's what cardiac output is. So if you want to increase your cardiac output, and look, it's normally about 5 liters a minute. You're exercising, it could be freaking 40 liters a minute, all right? So you can double it, triple it, right? So you do that 2 ways. The formula only has 2 variables. Either you're gonna increase your heart rate or increase the stroke volume. And the heart rate you can increase easier. But stroke volume, if you're in shape, you have more capacity to increase that because you have a stronger heart to get rid of it. But even athletes, the heart rate, you can double that. Stroke volume, you can bring it up like 1.5 times, but you can't, not much more, but those 2 things. And you'll understand if you're in good shape, it means you have a good stroke volume. You empty a lot of the blood out of that heart with each beat. And therefore you can have a slower resting heart rate. If you're not in shape, that means your heart only squeezes out a little bit of blood. To compensate, you gotta have your heart rate go up. One thing I should say is that if your heart rate goes really fast, that's an issue. As your heart rate goes up, there you end up with a kind of an asymptote because you can't have it go like a hummingbird, because it doesn't give it time to fill. So when you really crank up your heart rate, you have decreased the time for heart filling, and it actually works against you. So you don't you don't linearly, as your heart rate increases, cardiac output increases, it's going to a point, but you can't flutter it because then it doesn't have time to fill. So you need to be able to fill and empty, fill and empty. But if you can do it faster, that helps to a point. And this just shows, of course, on your pacemakers, you've got the parasympathetic nerve, the vagus, which secretes acetylcholine, which will slow it down. And the sympathetic nerves secrete adrenaline, epinephrine, which will speed it up. And then epinephrine, or adrenaline, will not only speed up the heart, it'll make the heart contract stronger as well. And then what records blood pressure? They're called pressure receptors. Another name is baroreceptors, so know what that is. And these things are found in us, in our aorta and in our carotid arteries. And the nerves go back to our medulla oblongata, to that cardiac center, which will either speed it up or slow it down if your blood pressure drops or is too high. Know Frank Starling's law? That means the more stretched cardiac muscle is, the stronger it contracts against that. And it's kind of a regulatory thing so that all the blood to the heart is gotten rid of. If you have just a slow trickle of blood, it doesn't beat very strong. If you have a lot of blood, it's really stretched, it goes hard. Venous return, we have a real problem getting blood back to our heart. So it's our muscles that help squish the veins, and because there's valves, it'll bring it back up. And our respiratory pump is simply when we inhale, it's going to squeeze our guts, and it's going to make a vacuum in our chest, and blood tends to suck back up towards the heart. All right, so hopefully you guys got this. Cardiac output is heart rate times stroke volume. And heart rate is determined by sympathetic and parasympathetic, rest or fight or flight. And stroke volume is how strong your ventricle muscles contract and how big your heart is. So the Frank Starling law is going to be one thing. And then you can increase contractibility with adrenaline to make it go stronger. And that Frank Starling law, of course, is how stretched the muscle fibers is. Well, it depends on your venous return. It's going to be that venous pressure. What's the blood that returns is going to stretch the heart and it's going to go stronger. All right. Well, I'm just going. Man, what are you guys doing? I guess you're listening to this, right? I kind of want to just hit everything. Yeah, if I had you here in front of me, I would be asking questions and such, but it seems silly to pause here and without any feedback, doesn't it? All right, that was your break. That was it. Back to work. Blood pressure, of course. And blood pressure is blood pressure, is how much force is on the walls of your vessels. And so I can feel, I have a strong blood pressure here. I feel a strong radial pulse. And when I feel it, when it goes out, when it pushes out, it's going to be my systolic pressure. And when it relaxes, it'll be my diastolic pressure, and back to systolic. So I have a pulse pressure as it comes out. It's directly related to my heart. There's a little delay, right? You guys know that delay. Your ventricle contracts, and then you feel the pulse, like 0.2 of a second, right? And the formula is blood pressure is going to equal cardiac output times peripheral resistance. The resistance is going to be the resistance to the flow, and it's mainly diameter. If you increase a small little straw, greater resistance. If you open up the vessel, less resistance. Yeah. And it's also length and viscosity. So basically, your blood pressure is influenced by your cardiac output, which are those two, and then your volume. I hope you guys got that. The more water you retain, the more blood you have, the greater your blood pressure. So the way we lower blood pressure is diuretics. You pee more water out, your blood pressure will come down. And then your viscosity, if you have really thick blood and you're really dehydrated, it's a little harder to push out than watery blood, but you don't change that a lot. But resistance, how much resistance in terms of really diameter of the vessels. If you open up all your vessels, the blood pressure will drop because your resistance when it goes down. Yep, baroreceptors, again, telling your cardiac center about your blood pressure. Yep, there's the formula. And again, looking at the whole thing, basically you should know your blood pressure is highest in your arteries. It's the highest in your aorta, or your ventricle and aorta. and then it just goes down and it just drops in the capillaries. You know, you just lose that blood pressure because it goes from a big vessel to millions of little vessels, which have an overall greater cross-sectional area, and it just slows down, and there's just miles of them. And so once you get to the veins, very little blood pressure. Look at that compared to the arteries. And then again, you see how pulsatile it is. It goes from systolic to diastolic. You feel that here at your wrist, but by the time you're in the capillaries, it's just kind of moving steady. It's no longer going like that. And here, what is resistance? It's going to be the length of the vessel, which you can't really change that. And then the viscosity. You can make your blood a little watery or thicker, I guess, but really radius to the freaking fourth power, all right? So you go from a radius of 1, you double it to 2, you go from a flow of 1 to 16 because it's to the fourth power. So huge influence is how big we make our vessels. And there's smooth muscle around them, so we can contract them, constrict, or dilate when they get big. You dilate your vessels, your blood pressure goes down because you have less resistance. You constrict your blood vessels, your resistance goes up, and your blood pressure goes up. All right. So you block an artery 20%. Does it block 20% of the flow? No, no, no. It blocks a lot more. You can see 20% occlusion, you're going to go from moving 100 volume of blood to 40, less than half of that. So a 20% reduction equals more than 50% reduction in flow. So it makes a big difference. Yep, so viscosity, length, and vessel diameter go into blood pressure. Once again, you can see the speedier blood just goes really slow through the capillaries. That's just what you want, to go nice and slow to exchange stuff, right? It goes quickly through the arteries, slow through the capillaries, and then quicker through the veins. Yep. And again, pressure just drops because the area goes up because you have so many capillaries. And once you have more area, cross-sectional area, less resistance. And so it slows down. Just like, I guess you could say, if you imagine you have a whole bunch of little rivers and then they all converge into one for a moment, and then they go back into a whole bunch of rivers. If you stood here and watched this, you would see it moving relatively slowly. But by the time, if you looked right here, it'd be moving really fast because it has the same amount of volume, has to go through in the same amount of time. And so when you have lots of big rivers that go slowly, when that water gets channeled somewhere small, it's got to go much faster. Yeah, I think you should get it. Blood pressure, right? I don't need to go through this. The central venous pressure is going to be how much pressure you have in that right atrium. That's where the blood's coming back to. And again, if that goes up, blood backs up into your body, and you end up with edema. Edema is this swelling because too much fluid. Too much blood pressure means more fluid's going to leave in those capillaries, and it's not going to come back into the blood. And so you have your tissues are swollen with fluid. Arteriosclerosis, atherosclerosis, hardening in the arteries. It's going to cause higher blood pressure, possibly even aneurysm, where the vessel blows up, balloons out anyway. And then hypertension is something that is really widespread, but see 20%, a third are not even aware. So it's a silent killer because unless you take your blood pressure, you don't know it's high. And if you find out it's high, you can regulate that with exercise and drugs and bring it down, because hypertension is a big killer. It's going to cause a stroke, an aneurysm. It's going to cause heart failure because it's too high a pressure. Your heart's working too hard. The vessels are being stretched. You can imagine, the danger of having too high a pressure in your system. So if we check it, and we have ways to fix it. And the ways to fix it depend on what's the cause of it. If you're retaining too much water, you eat too much salt, you can affect diets. You can take diuretics to make you pee more. If it's because your heart rate's always high, you can take beta blockers and things like that to slow that down. So there's ways we deal with hypertension, but you can see 1 billion people it affects. So it's a huge problem. And of course, exercise, you want to work up to that marathon, not wake up one morning and decide to run one, right? All right, then I had a lecture, online lecture, going through all the arteries and veins of the body. And looking over the test, I asked several questions. You need to tell me what the artery going to the kidney, which one of these arteries goes to the head, which artery is going to go to like the liver. So I'm going to ask you to make sure you've studied this and you know the major vessels of the body. So just write it on a piece of paper, the major arteries, and you can cheat, look until you learn it, and so you know it. All right. All right. Well, these you know pulmonary arteries going to the lungs, pulmonary veins coming back to the heart, inferior superior vena cava. Right. In the lungs, we talked about pulmonary edema, where if the pressure is too high, if your heart's failing, that fluid fills the lungs. Here it is, pulmonary edema. There you go. I put some more slides in here. I won't just stop here, but basically this, do you know this? Can you tell me what the arteries of your arm are, the arteries of your legs are, the arteries of your head? I don't ask all of them, I only ask a few, but you need to know these ones that I talked about, right, in this lecture. Yep, so here's the aorta, descending aorta, cervical thoracic, and then this will be abdominal aorta. Could be these common iliacs over your ilium or pelvis. Then you have an internal iliac, and the external iliac turns into the femoral in the leg. Then it's popliteal behind your knee. That'll be an anterior and posterior tibial down to your foot. All right, to your arm, coming off the aorta, you're going to have a brachiocephalic trunk, and that's going to turn into your common carotid and subclavian going to your arm. And then on the left, your common carotid and subclavian come right off the aorta. You don't have that brachiocephalic trunk. The common carotid is going to turn into an internal to go into your brain and an external to go in your face and your tongue, everything like that. And then you have vertebral arteries that go up your vertebral column, and they will meet the internal carotid to make this circle that's going to deliver blood to your whole brain. And then your arm, the subclavian, is going to turn into the axillary in your armpit, axillary. Then it's your brachial artery in your arm, and then it'll just be radial and ulnar artery, right? And so your radial pulse is what you feel beneath your thumb. And then getting to in the abdominal cavity here, you're going to have renal arteries go to the kidneys, suprarenal go to your adrenal glands. And then there's three that come straight off. So there's going to be a celiac trunk, and that's going to go to your liver and your spleen and your stomach. Then you're going to have a superior mesenteric, goes to all your small intestines and some of your large. And then an inferior mesenteric goes to the large intestine, your colon, and the stuff at the end there. So you have three branches that come off the midline. Take a look. So this, I just told you all. We'll go through it again. So you can see here's the aorta right here. You're going to have brachiocephalic trunk, and it's going to have common carotid and subclavian. And then your left common carotid and subclavian come off separately usually because the aorta arches to the left. Yep. So as I mentioned, celiac, superior, and inferior mesenteric come straight off the middle. And the other ones are all paired. So renals go to the kidneys, suprarenals to the adrenal glands, gonadal goes to your ovaries and testes, and eventually the aorta turns into the two common iliacs that will go in your pelvis, eventually to your legs. Oh, there we go. Yeah, I started to. And then looking up, I feel it here, my carotid pulse, big artery on either side. So your common carotid comes up, then it splits into internal carotid going to my brain, internal brain. External comes up and goes to my tongue and my teeth and my face and my scalp. And then the other one besides that's going to bring blood is the vertebral. See that inside the vertebrae? That vertebral goes up on either vertebrae through those holes in the cervical vertebrae, through the foramen magnum. It's going to meet the carotids to make this circle at the base of the brain. Yep. There'll be a cerebral arterial circle. The two vertebrals will come up, actually come together, and then the two big common carotids come up to have this circle. And this will equalize the pressure and give blood to your whole brain. Oh, there we go. And the arm, again, you're going to have subclavian, gets underneath your clavicle. We call it axillary in your armpit, brachial in your arm. and then it will split in the thumb and pinky side to radial ulnar artery. Intercostal arteries will come off the aorta before it hits the diaphragm. So between each rib, right? Intercostal. Yeah. Lower limb, that common iliac I mentioned, that big split you're going to have in the aorta is going to make an internal version, and then the external version is going to go out your leg, all the way down to your foot. So internal iliac, external iliac, and then it's femoral. Once it goes out into your leg, the back of your knee, it's going to be popliteal, and then it will go to the front and the back in your calf. Telling you like reading to you a map, this is what happens, but you just got to memorize it. You need to be able to do this. All right. So you can see here's the common iliac. It's going to be an internal going to all your stuff in your pelvis. The external is going to leave and go out your leg, the big femoral. It's going to do the back of your knee. So you go to the back of your knee to be popliteal in the back of your knee. And then a branch will go to the front of your calf, and you can feel your pulse sometimes at the top of your foot. And then one goes deep underneath your calf muscles, the anterior and posterior tibial. The veins. So the veins have the same names as the arteries. And then we have superficial veins that I had you learn, 2 in the leg and 2 in the arm. Well, 3 in the arm, I guess. In the head, this is the jugular veins. The jugular veins are going to drain. The big internal ones drain your brain, and the external one will drain your face and your tongue. And these jugulars come down to make that superior vena cava. Right? And the vertebral vein, it runs with the vertebral artery. And then so we had superficial veins of the arm, which are kind of important, because we take blood from the arm often. And just need to know on the outside of your arm and your thumb side, all the way up is this cephalic vein. So thumb side all the way up. Yeah. And this is in your skin. This is just in your skin. You can see this valve on that vein on some people really coming up the outside of their biceps. On the inside in your arm, it'd be basilic. And basilic comes up the inside of your arm. And then right in this is called the cubital fossa, in this elbow region here, this median cubital vein. So you need to know this is the cubital fossa. The back of your knee is the popliteal fossa, like popliteal artery. So the median cubital vein here, there's a connection between the cephalic and basilic. And that's often where blood is drawn. We look for vessels there in the arm. I taught you, and we're going to get to this, the digestive system, but if I ask you what the hepatic portal system is, that is going to be arteries take blood to your guts, your intestines, where you absorb nutrients. And then the vein does not go back into the inferior vena cava. The vein then goes to the liver. And so it's going to deliver blood from the intestines in your stomach. The portal vein is going to deliver it to the capillaries of your liver. So your liver is this huge organ that takes all the blood from absorption. So it takes care of sugars and alcohol and toxins. Your liver gets that first crack at it. And absorbing blood from your gut, there's probably bacteria in it too. And so your liver has macrophages to help clean the blood too. Yep. So everything from your intestines and your stomach and your spleen and pancreas happen to go through the liver. All right. And finally, a couple veins in the lower leg. You need to know the great saphenous. Your longest vein goes all the way down from your foot on the medial side of your calf, medial side of your thigh, and then it goes in. Here it is here. That's the great saphenous vein. And the small saphenous vein is much smaller. It goes on the lateral side, the back of your, the outside of your foot, that lateral malleolus, and it goes up your calf, and then it goes in the back of the knee. It doesn't go all the way up. All right, and so, just don't forget the arteries and veins of the body. I mean, I know you're concentrating on the ECG and blood pressure and heart and valves, things like that, but also cardiovascular system includes all these vessels. So ask questions, make sure you're ready for that. Lifespan changes. I think your heart, it enlarges, but not in a good way. When it gets more of the muscle turns into fat and connective tissue. So you guys with your young hearts, it's all muscle, it's strong. You can have a lower heart rate, good stroke volume. But many people, elderly people, heart works just fine. And it's often because they don't often get their heart rate up. They don't, they're not playing football and things like that. So if you test an old person, I mean, they may be fine for normal activity, but they could not, crank it up to run that marathon. Yeah, definitely. Blood pressure, of course, increases with age, right? Definitely. And the big thing is arterial sclerosis and that hypertension is that as you get older, we just get narrowing of those arteries. And when they narrow in the heart, especially, you're at risk for a myocardial infarction or heart attack. All right. All right. I don't know, how long did this take? I'll have to take a look, but yeah, I hope this is useful. I mean, I lectured on all this once. All right. And so this is me going through it again so that, and again, I'll take feedback, if this is, it's not that useful, then, just listen to the original lectures. But hopefully you listen to something at this point in the semester, and the test is on Monday. This is familiar to you. All right. And so hopefully this is a good review. All right. I wish you guys the best. And put this up there.